just answer that door.
That's fine. Yes.
Okay, so we're going to join. Hello, everybody, and a very warm welcome to the School of Nursing, Midwifery and Health Systems Breastfeeding and Lactation Webinar. My name is Niamh Vickers, and I'm absolutely delighted to be co-hosting today with my colleague Denise McGuinness. We are both so thrilled to see such a fantastic turnout. We understand that over 200 people have registered for today's session, which speaks volumes for the importance and interest in the area of breastfeeding and lactation. We have a very engaging webinar planned for today, featuring 3 distinct presentations from our 4 expert speakers. They will be sharing their insights and knowledge on various aspects of breastfeeding and lactation within health systems. So just a quick note on the format of today's webinar. So all attendees have been muted, and that is to ensure a smooth listening experience for everybody. However, we absolutely do encourage participation through the question and answer function. So if you have any questions at any time, please post them through that function, and we will be having a dedicated Q&A session at the end of the presentations today. So the webinar is being recorded and it will be posted on the School of Nursing, Midwifery and Health Systems YouTube channel after today's event. And now it's with my great pleasure to introduce our first speaker, Caoimhe Whelan, who is an IBCLC in Churchtown in Dublin. And Caoimhe researched women's experiences of breastfeeding with primary low milk supply as part of her MSc by research in the School of Nursing, Midwifery and Health Systems in UCD. And articles on Caoimhe's research have been recently published in Breastfeeding Medicine and also the International Breastfeeding Journal. And Caoimhe's book, which is called Practical Breastfeeding, an Illustrated Guide for Parents, will be published next month in June. So a very warm welcome to you today, Caoimhe, and I'm going to hand over to you to share your presentation.
Great. Thanks very much for the lovely introduction. Niamh, that saves me some of the work. I haven't introduced myself. Now let me just get organized here with my slides. Okay, so yeah, I work in private practice in South Dublin, and I share an office with a colleague. It's an office-based practice, and a couple of years ago, I finished my research on women's experiences of breastfeeding with primary low milk supply. And as Niamh very kindly said, I've written a book, which is published on the 5th of June, which is it's quite exciting. And I worked with an illustrator, so it's a colour illustrated guide. So there's just a little bit about me, and just to give you a snapshot of the kind of people that I work with in my private practice in Dublin, they tend to be, I suppose, what we call older moms, over 35 or somewhere between 35 and 45, you know, middle class, professional, educated. Most of them would come from NMH. A lot of them have had IVF. And over the last number of years, I've noted an increase in the number of people ticking that anxiety box in intake forms, and of course a lot of them will have had C-sections. And I suppose I do attract quite a lot of people who struggle with low milk supply because of my research in the area, and because I run a monthly support group for mothers who have low milk supply. I contacted UCD a couple of years, well, it was 2020, beginning of the lockdown, and I had an idea to undertake qualitative research on what it is like to have primary low milk supply, because I identified a gap in the research. And long story short, I did a master's by research and used a research method called interpretive phenomenological analysis to explore the lived experiences of mothers who had intended to exclusively breastfeed and then discovered that they were unable to. They just simply could not make enough milk to exclusively breastfeed their babies. So I suppose that's where a lot of my insight and knowledge about low milk supply comes from. And as Niamh already said, I've published 2 papers so far. Hopefully there'll be a third in the not too distant future, but those 2 papers there came from 2 separate themes from my research. So just on low milk supply more broadly, it is the most common reason why women, or the most common reason that they give for ceasing breastfeeding prematurely or before they had wanted to. Now, in some cases, it's not low milk supply at all. It's a lack of understanding of normal newborn behavior, but a certain cohort of those mothers will have primary low milk supply. And either way, it warrants attention. This is an important topic. Whatever the reason for the low milk supply is, I think we really need to be educated about how to support mothers who are struggling with supply. So just to give you a sort of a brief overview of what we're talking about when we talk about low milk supply or not enough milk or low milk production or insufficient lactation. There's a plethora of terms that are used to describe it, but actually no consensus really on what is the most correct term. So perceived milk supply, low milk supply is something we're well aware of, and it has been documented in the research. So essentially where a mother lacks understanding about normal newborn behavior, what breastfeeding looks like, and feels that she doesn't have enough for her baby. And anybody working in breastfeeding support groups, will see this quite a lot. It's very common in the early postpartum period. And then we have delayed lactogenesis, and there are lots of reasons why milk might be slow to come in or increase in volume. C-section, it could be retained placenta. Oedema is one that I see quite frequently, or high blood pressure. But, it's not uncommon to see situations where a mother's milk does not increase in volume until around day 4, 5, 6, or 7. But many of these women can go on to then make a full milk supply. Secondary low milk supply is where the cause of the low milk supply or production is extrinsic. So it's external factors have resulted in that mother not producing enough milk to meet her baby's needs at any given point in time. I find from my work, generally, this can be turned around and we can bring production up again. But there are lots of reasons why supply might drop. It might be not enough breastfeeding or suboptimal milk removal or certain medications. But that's not what we're talking about today. What I'm talking about is primary low milk supply. So where there's an intrinsic cause. It's nothing the mother has done. It's something to do with her innate physiology or anatomy, which has resulted in her not being able to exclusively breastfeed her baby. Lots of different reasons why a mother might not be able to exclusively breastfeed. It could be hormonal, it could be due to breast surgery, metabolic issues, obesity, diabetes, and it could also be IGT, insufficient glandular tissue, where there isn't enough of the milk-making tissue in the breasts to be able to exclusively breastfeed. And this is certainly the number one cause of primary low milk supply that I would see in my practice. And from my research as well, out of the 9 participants that I interviewed, 8 of them reported that they had insufficient glandular tissue. And I think there is a growing awareness now about this condition. Renee Cam is a researcher in Australia, and she's done quite a few papers in the last few years looking at insufficient glandular tissue, because, up until a few years ago, there was really very little knowledge about it, sometimes called mammary hyperplasia. And generally, mothers who have this kind of hyperplasia will not exclusively breastfeed. The physical characteristics can be identified antenatally. But that said, there's still no way to tell how much milk a mother is actually going to make. And I've seen mothers where they have what looks like really obvious IGT breasts, and yet they go on to make lots of milk. So we can never tell for sure until that mother has her baby and initiates lactation and starts to breastfeed. Generally, where there's IGT, there'll be wide spacing. That kind of shape that you see in the photograph there, kind of lack of glandular tissue on the underside of the breast, a bulbous areola. Quite often there's asymmetry, and sometimes you'll see stretch marks as well. And you know, it's not always really obvious. Sometimes mothers with quite big breasts can have insufficient glandular tissue. And in talking to these mothers, you'll often discover that they experienced minimal breast changes during pregnancy. Quite often they'll report that during puberty, their periods were very irregular or very heavy and very painful. There was research, or actually it was Renee Cam in Australia. One of the findings of one of her studies was that there's an association between IGT and obesity during puberty. So these are just some of the things to tease out with mothers when you're working with them. We can't say with any certainty why some people have IGT and others don't. There may be genetic factors. Who knows? We certainly need more research in this area. What I found in my work is that generally these mothers will experience a delay in lactogenesis, that it isn't the dramatic event that mothers who don't have IGT have, where maybe on day 3 breasts are big and full. It's more of a slow burn. You know, it's more gradual, not very dramatic, and they may not reach full milk production until about 5 or 6 weeks down the line. So I want to give some tips now for people supporting mothers, whether it's antenatally or postnatally, working with mothers who have primary low milk supply to help them. This is a big topic, and I'm limited in what I can go into during this half-hour period. I can't get sort of too deep into sort of clinical protocols, but hopefully there'll be some tips that might be helpful for people. First off, antenatally, if you are delivering antenatal classes, I feel, or antenatal breastfeeding classes, it is incumbent upon you to provide information on primary low milk supply, to normalise it, to let people know that there is a small possibility they will have IGT, and also to talk about other breastfeeding difficulties. And there are a lot of studies coming out at the moment, you know, saying we need to talk about breastfeeding difficulties. We have got to stop saying to mothers, everything's going to be fine, just get enough support and everything will be wonderful. We need to be honest about the fact that for some people, breastfeeding is really difficult. We can identify some of the risk factors for primary low milk supply so that mothers can then get individualized antenatal support. And something else I think that it's important to include in antenatal breastfeeding classes is the emotional dimension to breastfeeding, because I find from my work that this is something that many mothers are not prepared for. And let people know that breastfeeding is about experiential learning. It's not just about, you know, gathering all the information antenatally. It's about learning as you go. And this can be helpful for people who are experiencing breastfeeding difficulties. When we normalize challenges, it enhances the mother's belief that these challenges can be overcome. Nobody wants to be told that, oh, that's very rare. Oh, I've never seen that. When we say, yes, this is a thing, we may not be able to totally fix it, but you can breastfeed, and let's look at ways that we can help you. Normalize challenges, and there's ample research that supports this idea. In terms of individualized antenatal lactation support, these are some of the things that we can advise mothers to do. Antenatal expression of colostrum, Some people find it really empowering, other people are just not interested, but if a mother expresses an interest in it, it might be helpful for her. Support a mother to develop a feeding preferences plan that she can put into her hospital file. And it can be really simple. It doesn't have to be, you know, a big production, but just to let staff know maybe she'd like her baby to have colostrum as her first feed, to let staff know that she has some risk factors for low milk supply and that she'd appreciate extra support. The feedback that I get from the mothers that I work with is that staff go the extra mile when they see something like this in the mother's file. It helps them. It's a really valuable communication tool. We can give mothers tips for optimizing milk production in the first few days, like lots of breastfeeding, lots of skin to skin, hand expression, as well as breastfeeding. All of these things can hasten milk coming in as well. And stress to mothers the importance of skilled support and also peer support after their baby arrives. We can also let them know that breastfeeding doesn't have to be all or nothing. And I think sometimes because of the way breastfeeding is taught in classes, people come away with the idea that it's either you breastfeed or you formula feed. You pick one or the other, and there's nothing in between. And often these mothers, they find themselves in this kind of no man's land that they didn't even know existed before they had their baby. Breastfeeding is an embodied practice, and one of the things to remember when you're working with women who are not making enough milk is that they can hold very deep embodied emotions that even they can't understand. They just can't get their head around because nobody has ever talked to them about the kinds of emotions that can go hand in hand with breastfeeding, or that it can go hand in hand with their motherhood self-identity. I mean, that in itself is a presentation on its own. So I'm going to move on and talk a little bit about sort of the first few days postpartum and what can we do to help. You know, if you're working in a hospital, on the postnatal wards, lots of this, keeping the mom and baby together, lots of skin to skin, cuddles. Tuck your baby down your nightie, just keep them close. This side, lots of switching from side to side. And if you can, a little bit of hand expression after a feed, even if it's like a few more drops. And this can just help the mother feel empowered that she's doing everything she can, even if, you know, she goes on to experience low milk supply. She knows that she has done everything in the first few days that she can possibly do. Monitor closely. We're going to look at nappy output and how is the baby doing, weight on maybe day 3. And if possible, try and delay supplementation with formula. If the mom has some hand expressed colostrum, maybe she could give that to the baby. But even if she can get 2 or 3 days of just colostrum, you know, that can be, it can be a real sense of achievement for a mother. And I know this is you know, it's difficult in the hospital setting where, you know, you may feel sort of pressure to encourage the mother to supplement. There are situations when absolutely that baby needs extra milk. If the baby needs infant formula, appropriate feed volumes. You know, on day 2, not 30 mils or 40 mils or 60 mils, small volumes. And also consider how you're going to suggest that the mother give her baby the extra milk. Now, it may depend on the policy in the particular hospital you work in, but there are alternatives to bottle feeding. It could be cup feeding or using a spoon or using a syringe where there are small volumes. Beyond day 3, I suppose most of the mothers who come to me with low milk supply, this is the kind of plan they've been given on discharge from hospital, a very generic plan. And I'm not dissing this. I understand that people are under pressure and it's difficult. But for somebody who may have primary low milk supply, or certainly supply is going to be an issue, this generic plan is not what they need. They need individualized support, somebody to look at, you know, their situation, how much their baby needs, whether they're going to pump, because often moms are just told pump pump after every single feed. It may be a situation that a mother feels she's able to pump maybe 2 or 3 times a day. Or she might say, do you know what? I don't want to pump at all. I did it on my last baby. I don't want that thing to come near me. So we have to work with the mother and try and figure out what's going to be the best solution for her. And if her baby is feeding well at the breast and getting most of the available milk, she may not need to feed. If a mother is triple feeding and that's the plan, on discharge, there has to be a time frame put on that triple feeding plan. I actually saw somebody during the week who on discharge from hospital was told to feed her baby every 2 hours and pump and then bottle feed. She did that for 3 weeks until she got to a point where she was nearly on the verge of a nervous breakdown. We cannot do this to mothers. And it's sorry, I'm getting a little bit worked up and emotional because it really damages a mother's, or it has the potential to damage a mother's mental health. And, you can't go back and replay those first few weeks with the baby. So we just need to be very careful about this guidance around triple feeding. We have to find a plan that's going to be manageable for a mother. How to supplement, there are lots of ways to do it, bottle or supplemental nursing system or a homemade supplementer. I don't have time to go into that today. But as I already said, put a time frame on the plan that you give the mother when she is leaving the hospital and direct her to some kind of community support, whether it's a public health nurse, a public health nurse IBCLC or an IBCLC in private practice, somebody who can give her time and support her with an individualized plan over a period of weeks, because it's not just about seeing somebody one time and then fixing everything and moving on. I've said it already, individualized, skilled, and sensitive support. Sorry, that's my dog barking in the background, if you can hear him. What's going on out there? Anyway, just a reminder about weight loss and weight gain in the first week. Generally, we expect to see a gain or a baby start gaining on or around day 6 or 7. Quite often, I see mums who, day 4 or 5, somebody weighs the baby and there's absolute panic stations when that baby hasn't started to gain weight. We need a few days between milk coming in and then to see this increase in weight. So just to be mindful of that. And if we're not seeing an increase by about day 7, there's something going on, and milk supply should certainly be investigated. This is really important. Let the mother know that milk production may continue to increase right up to 6 weeks. People often have this very fixed idea about milk production, that milk comes in on around day 3 or 4. And then, if they don't have a full milk supply by the end of the first week, well, that window is closing and it's a disaster and they can't increase their milk supply. And this is what I see with people who have low milk supply, that it's a slower burn. Gradual increases can be seen, right up to week 5 and week 6. And just letting mothers know this can give them hope and help them feel that, they're going to get out of this difficult spot. Generally, where, a mother has primary low milk supply, she'll be supplementing her baby with infant formula. As healthcare professionals and IBCLCs, we need to be mindful that this may be very upsetting for mothers. They may have a sort of a narrative in their head about infant formula that it's, it's poison and it's the worst possible thing. So we need to be very sensitive around this and not be dismissive. Sometimes mothers can perceive the message that, oh, they're all the same, just pick one, as dismissive. They want comprehensive information about how to use it, where to buy it, what type, not what brand. But, if you go to a local supermarket, you could see so many different types of formula and stages. So just really clear, comprehensive information and direct them to reliable evidence-based sources, whether it's UNICEF or the NHS or HSC, it's important to give them this information. Do not assume that they know how to prepare infant formula safely. So guidance on all of these things, and talk about giving a bottle in a loving way. Haste feeding, of course. And sometimes a shift in perspective can make a difference to a mother. Let her know that feeding her baby these extra calories may help to protect breastfeeding and prolong her breastfeeding relationship. Formula is not the enemy. In terms of how much to supplement, it's very hard to put a number on it. I see some mothers being advised to pump for 24 hours, stop breastfeeding, and see how much milk you get, and then we decide how much supplementation the baby needs. I don't recommend that. I don't think it's a good idea to interrupt breastfeeding like that. There are a lot of moving parts, supply increasing, baby developing breastfeeding skills. So we just need to watch closely. We might try a number like 300 mils per 24 hours, weigh a number of days later, calibrate up or calibrate down. It takes a little bit of work in the first few weeks to arrive at an approximate number, but it's not as simple as doing a test weight and saying, oh, the baby took 30 mils, so therefore baby need, it's just I personally don't think that's the way to do it. And of course, we're going to be watching closely, looking at nappy output, looking at baby's weight gain, looking at how the baby is, and really communicating with the mother and encouraging her to tune into what's happening with breastfeeding. Yeah, I just said that again there. People might disagree, but I don't think this is a good idea, and I just see a lot of it happening at the moment. Triple feeding. I know I'm running out of time. You can go back over the slides if you want, but these were things that participants in my research said about triple feeding. It had a devastating effect on their mental health. Mothers who could not think about anything else. And actually, a mother I saw during the week, she cried and she said, I spent more time with the pump than I did with my baby. And that's time she'll never get back. Okay. And that was a finding from one of my studies, that the combination of primary low milk supply and triple feeding can negatively impact a mother's mental health. So put a time frame on it. And whatever care plan you give to this mother, at the heart of it must be her relationship with her baby. How to nurture her baby in a loving way, never mind how she's feeding the baby and her mental health. But there must be space for her to enjoy her baby. And the emotional impact of primary low milk supply is massive. And again, just things that participants in my research said about the first 3 months postpartum as mothers with primary low milk supply. There was one mother who even had a fear that her baby was going to be taken away from her. And like, I'll never forget this, and I still have that image of her in my head, of her sitting on the end of the bed crying, thinking, if I can't take care of her, they are going to take her away from me. And so just to bear that in mind and to remember how sensitive we need to be with these mothers, because it can be a really devastating, difficult time for them. Just a little bit more on the emotional impact. Whole lot of words there. The positive is that these mothers do come through to the other side. They may be traumatized. So while we provide lactation and breastfeeding support, give them space and listen and give them kindness and be empathetic, acknowledge and validate their feelings. Be mindful of the risk of postpartum depression, and in some cases it might be appropriate to screen for postpartum mental health disorders, or to refer on to appropriate supports. These are just a few things, I suppose, just in general, not low supply specific, but working with mothers, validate, reflect back, individualized plan, open-ended questions, build rapport. You want this mother to be able to trust you. And if you know, primary low milk supply is not in your skill set. Refer on to somebody who can provide appropriate support. Sometimes you need teamwork. We might need a public health nurse and a lactation consultant and a voluntary supporter and a GP and a mental health professional to help that mum get through a difficult time. I know I'm running out of time, so I'm going to go through that slide quickly and finish up. These are just some things that I would recommend you do not say to a mother who has primary low milk supply. They are not helpful. And this comes from my research and also from my practice. At somebody last week who was told you might not be able to breastfeed. It's not black and white. Mothers with IGT and primary low milk supply can breastfeed. It might not look like how they had expected, but they can breastfeed and find a way to make it work for them. The first one, your baby is starving. This does happen, unfortunately. Yeah, and I think I've said that already. All formulas are just the same, just pick the cheapest. Not helpful either. Also saying IGT is very rare. Nobody wants to feel like they are an anomaly. And I remember one mom saying to me, I felt like a freak, that she was somehow so different from all the other moms. So we need to be able to say, yes, this is a thing. I know about this, or, oh, I've heard about this. I'll do some more research. But, there are other mothers out there with IGT or low milk supply. While the first 3 months are really difficult, I find generally mums do get to a really good place. They work through all of these difficult emotions and get to a place where they can feel proud of themselves, proud of all the work they've put in, and know that they did the best that they could. Remember that primary low milk supply, it's an ongoing journey, requires ongoing support around sleep and solids, and has many ups and downs. And that was just a sort of a little image I did there to sort of help you visualize the first 12 months. It's not just about getting support in those first few weeks. It can also be difficult when baby starts solids. Providing sensitive and person-centered support to those with primary low milk supply. We want to promote breastfeeding self-efficacy, good communication skills, no false assurances. Language really matters. Normalize primary low milk supply, hold space, consider the implications of triple feeding, and remember that it's an ongoing journey. I think I'm at the end. These are the things that a mother with primary low milk supply needs. And then finally, just to mention that as an IBCLC, there's a big emotional load sometimes working with these mothers who may have a lot of trauma and distress. So make sure that you are supported or that you have colleagues you can speak to. And you don't always see the outcome you would have hoped for, which can be difficult as an IBCLC. Very occasionally, mothers can direct their anger or difficult emotions towards you when they're in a dark or difficult space. So that may not be about you, but about what this mother is going through. And I'm done. I think I've won. No, yeah, that's it. 35, yeah, 12:35. And I think, Niamh, the questions are at the end of the webinar rather than now. Okay.
That's it. Caoimhe, thank you so much for your presentation.
Okay.
Absolutely fantastic. So
Thank you, Niamh.
wealth of information and insights. And we will be taking questions at the end, Caoimhe. So thank you so much. And I'm going to hand you over to Denise McGuinness, my co-host today, to introduce our next speakers. And I will be sharing the slides for this presentation.
Thank you, Niamh. It's my pleasure to introduce our next presentation, which will explore 2 memory aids for breastfeeding, CHINs and LATCHES. We are delighted to welcome our next speakers, Dr. Lynette Shotton and Cheryl Elliot. Dr. Lynette Shotton is a registered adult nurse and a specialist community public health nurse, which is a health visitor in the UK. Lynette has been working in academia since 2008 and is currently an associate professor in the Department of Social Work, Education, and Community Wellbeing at Northumbria University. Lynette's research interests focus on developing the breastfeeding workforce and understanding and addressing educational inequality. Joining Lynette is Cheryl Elliot, who is a registered adult nurse and midwife. Cheryl has been working in academia since 2018 and is currently an assistant professor in the Department of Health and Life Sciences at Northumbria University. Cheryl's research interests focus on developing the breastfeeding workforce and understanding the experiences of pregnancy and first-time motherhood for women aged over 35. We look forward to your presentation now.
Oh, thank you. And thank you very much for inviting us to talk about our work. And I'll just correct something that Niamh said at the beginning when she referred to me as an expert. I am definitely not an expert at all. And really, other than my work around chins and latches that we're going to talk about today, I don't really do anything around health anymore within the context of my academic role. So it's really nice for me to keep this strand of my work going. Just if we can go on to the next slide, Niamh, if that's all right. And apologies, we can't move the slides on ourselves. I think it's something to do with the fact that our university, we don't really use Zoom. So Niamh's kindly moving those on, and probably on to the next one if we can. But thanks for introducing us. So today we're going to talk about really two memory aids, and our work is very much focused on practice and really, I suppose, supporting the breastfeeding workforce with some very essential practical skills. And so we're going to look at chins first, and then some of the work and research that we've been doing around chins. And then we're going to talk about a new memory aid, which is called LATCHES, and Cheryl's going to detail a regional pilot that we carried out recently to understand the feasibility and the applicability of LATCHES. And then we're just going to think about the importance of our work in the broader context of breastfeeding, education, training and workforce and practice delivery. So if we can just go on to the next slide. Our work is very much focused on these two areas, really. And chins is focused on positioning, and then LATCHES is thinking about the principles of attachment for effective breastfeeding. And the reason that we're focused on these key areas is that, if we don't get these two things right, sometimes that can impact on whether women will breastfeed for as long as they want to do so. So positioning is essentially, sorry, thanks, Niamh. Positioning is essentially the relationship between mother and baby's body, and really how mothers hold the baby to really help them attach effectively to the breast. And there are lots of sort of images in the media and from people that we see feeding babies around us that sometimes make us interfere with really what a baby's innate skills. And so sometimes it's how we hold babies too high, or sometimes clothing can get in the way, hands can get in the way. So the principles of positioning are really quite important. And we know that some of the challenges or the issues that mothers present to practitioners with, for example, sore nipples, mastitis, some of those can actually be underpinned by ineffective positioning and attachment. So just if we can go on to the next slide, that would be great. We just wanted to point out that we have developed a short video and that's embedded into this presentation. We're not going to show it today because it's 8 minutes in length, but just if anyone wants to sort of review that, I'm sure that the slides will be circulated. It's just a bit of a recap and an overview of our work. So again, if we can just move on, Niamh, that would be brilliant. So in terms of the background to chins, I know that certainly Niamh and Denise have been aware of chins, but if I don't know if others on the webinar are, but basically chins is a first letter mnemonic, and I developed it quite a long time ago now, so that was my maiden name. I developed this in 2011, and this was really something I developed as part of my own UNICEF baby friendly initiative training. So back in 2010, I was working as an academic at Teesside University, and I was approached by an infant feeding lead in our region in the northeast of England to really request or ask whether I'd be prepared to have our health visiting provision accredited by UNICEF Baby Friendly Initiative. Now, you might not be aware of the Baby Friendly Initiative, but certainly in the UK, it's really become the preferred breastfeeding education programme across the United Kingdom, really. And it's embedded in the NHS plan and lots of our professional guidance. But back in 2010, what we found was that a lot of our maternity services were accredited, a lot of community services were accredited, but UNICEF then started to initiate work to have universities that would train in the future workforce accredited. And so Teesside University, we worked towards accreditation, and we were the third university in the UK to be accredited, and certainly the first in our region. But when I was approached, I actually felt a bit like a fraud. So when I said I wasn't an expert, I really reflected on my ability to lead this accreditation process, because I'm sort of embarrassed to say that as a health visitor, I didn't receive any training on breastfeeding. And so when I went out into practice, I felt very inadequate. And when I reflect on some of the mothers that I was trying to support, I'm not sure that they got the best possible support. And so really at the time, I didn't feel that I could actually develop a curriculum based on my own lack of expertise. So I actually asked the NHS regional infant feeding lead to pay for me to do the UNICEF training. And so I did the initial training and then the train the trainer training. And I was asked to deliver a presentation on positioning as part of that training. And once again, I felt, wow, this is going to be really difficult because I'm surrounded by experts. How will I be able to remember those principles? And that's really when CHINS was developed. So CHINS was based on breastfeeding theory that was delivered during that UNICEF training. And each of the letters relates to a word or phrase outlining a principle for effective positioning. And the idea behind CHINS, and I'm going to talk you through it over the next slides, is that we shouldn't just remember CHINS and CHINS. We should actually be thinking about the explanation and the rationale for each of the principles, so that practitioners know how to support positioning for effective breastfeeding, but also why. So I think, can we go on to the next slide? So this memory aid, and I don't know if any of you use memory aids, but certainly throughout my nursing career, memory aids have been a key feature of practice. So I'm thinking, you know, in accident and emergency, we used to refer to RICE if someone had an injury, perhaps, and certainly in nurse prescribing, we used to refer to a lot of memory aids. So they were naturally something that I was using. And so really for me, when I developed CHINS, it was about trying to create a structure that made sense, but also a way that I could remember, retain and recall the principles for positioning so that I would be able to then use them. And so these are the kind of the letters and really what they represent in terms of the principles. So the first one is C, so close. And this sounds really obvious, that babies need to be close. But actually, as I said initially, we sometimes interfere with that. Either we don't hold them close enough to actually the breast, or sometimes a hand can get in the way, or sometimes clothing. So baby does need to be close. And we need to make sure that things aren't getting in the way, such as baby's clothes or mum's clothes or hands. Head free, so H for head free. And again, when we think about sort of if we see other people feeding babies or formula feeding, sometimes heads are supported, and we've got this idea that baby's head needs to be really well supported. But actually, when attaching to the breast, baby will sort of tilt their head back. And so even, you know, a couple of fingers on the back of the head can interfere with that process. So we do need to make sure that baby's head is free. And then the next one, I for in line. And again, this sounds obvious, but sometimes we see positions that really can be quite uncomfortable. and can lead to baby having to twist their neck, which can impact on feeding and also swallowing. So we need to make sure that, you know, babies are in alignment so that it's comfortable for them. And particularly sometimes, you know, breastfeeding can take varying lengths of time. So we have to think about, you know, how long is a baby going to be in a position? And if they're not comfortable, then it's not going to be a nice position to be in to feed effectively. Next slide, please, Niamh. And then this one, in N for nose to nipple. This is perhaps one of the most important points, and this has been something that UNICEF and practitioners who use chins have said has been quite pivotal in terms of maybe changing practice that wasn't particularly helpful. So nose to nipple, this is the starting point for effective attachment, and that's regardless of what kind of hold baby and mum might want to use. But with mother's nipple resting below baby's nose, baby will begin to root, and then as baby tilts their head back, the nipple will slip under their top lip, upwards and backwards to rest between the hard and the soft palate. And then this last one, S for sustainable. So we need to ensure that both mother and baby's position are well supported and comfortable so that the position is sustainable for the duration of the feed. So this is chins, and I think the next slide, Niamh, I think is just really an example of where chins is being used. So I don't know, there should be a link embedded in that slide. I don't know if we've got time just to quickly show this. I'm hoping we can.
Sorry, Niamh, it might require a right click to open the hyperlink.
Don't worry, Niamh, if we can't, we can just maybe go back to the presentation. I'm just conscious of time, but oh, there we are.
Yeah.
So you might need to accept the cookie, accept the cookies, and then just scroll down a little bit if you could.
Yeah. Oops, sorry now. See if this will go down. There we go.
A little bit further. So this is just an NHS website, and so chins has been widely adopted really in UNICEF training since probably around 2012, and it's been included in lots of NHS information. So if we just scroll down a little bit further, we probably won't show this now, but this is just a video just talking about chins and you know, just giving an example of how it should be used in practice as well. So you might want to just have a look at that video later on in your own time. Can we return to the slideshow? Is that okay?
Lynette, that's perfect.
Brilliant. Thank you.
Yeah.
So, as I said, I developed chins during my own UNICEF Baby Friendly Initiative training, and the UNICEF staff were really impressed by it, and they just asked me if they could use it, and I just said yes, please feel free to use it as long as you refer to me. And then, as I mentioned earlier, I kind of forgot about it because my academic role doesn't involve anything really to do with health now. It's mainly around education. But it wasn't until my sister had a baby, and in the United Kingdom we call them little red books, but they're basically parent-child health records. And my sister came downstairs and she said, "Oh, Lynette, look at this." And in the record, the midwife had written "chins observed." And we had a bit of a laugh about it. Jill said, "Oh, that's your work, isn't it?" And I went, "Yeah." And we just sort of dismissed it. And then I thought, actually, this is quite important. And, you know, if a midwife is writing in their record, which is a legal document, that chins have been observed, this is really a sign that it's being used to demonstrate that good practice has been delivered. And so I thought really I should probably look into really finding out where chins is being used, and for me, like why are people using it? Because I dismissed it and I developed it really for myself. But in 2022, I got a small amount of funding from the Burdett Trust for Nursing, and I was able to conduct a mixed methods study. I won't go into too much of the detail, but I used a theory called normalisation process theory. And that really is a theory that helps us to understand how interventions are implemented, embedded and integrated into healthcare settings. And so this really was the formed sort of a survey and some of the questions that I asked through focus groups. If I can just go on to the next slide. So I adopted a mixed methods approach. And again, you can just see on the slide, you know, what that kind of involved. And then just on the next slide, I was able to have a survey that was UK-wide, but also I had some international respondents. There were 115 respondents to the survey. And as you'll see there, they were from universities, so quite a high number of university academics, health visitors, and UNICEF Baby Friendly Initiative educators. And most of the people who completed the survey were aware of chins, and they were aware of it really because of UNICEF. So because UNICEF had embedded it in their training, the staff felt that that was an endorsement of chins. And I'll let you just read that quickly, but if we can just go on to the next slide. This is kind of just a snapshot of what the practitioners and academics told me. So they were all aware of chins and they all really liked it. So they were really positive. Only one of the 115 respondents said that they didn't find chins helpful. They said that they felt chins was oversimplistic, but actually the remainder of the respondents, the other 114, said it was actually the simplicity of chins that was really why they were using it. And, you know, when I talk about my own practice, and, you know, I told you I didn't have any breastfeeding education, we actually have quite high levels of breastfeeding education now, and that's really because of the way that UNICEF training has been so embedded across the United Kingdom. But the challenge that we have is, in the United Kingdom, our breastfeeding rates are probably the lowest, among the lowest globally. And certainly in the area that I've been practicing in is the northeast of England, we've got some of the lowest rates in the United Kingdom. So one of the challenges that we've got is you can train the breastfeeding workforce, but then when it comes to putting that training into practice, some of the practitioners just aren't seeing anyone on their caseload who is breastfeeding. So staff can become de-skilled, they can feel that they don't have confidence. And certainly when I think back to my own caseload, I had a caseload of 1,000 families, and possibly only a handful of those mothers on that caseload would have been breastfeeding. So we need to think about sort of, you know, what do we need to do to sort of address that? And one of the things is that we need to make sure that, you know, for those handful of mothers who do need support, that support is effective. And, you know, sometimes we can signpost onto other services, but sometimes that's a challenge as well. So our work is around making sure that all staff have a certain level of knowledge, but they have mechanisms and perhaps memory aids like chins where they can actually have some level of competence. And one of the things that participants said was that chins does give them confidence, because it's something that they can remember. They can structure the information in a particular way, and they can remember it as well. There was also evidence that the staff were sharing chins. So there's, you know, you see on the slide there, it was shared with the breastfeeding network. And I did actually say, chins is really a small thing. And one of the respondents said, no, it's not, Lynette, it's massive. It's really an important part of what we do. I also asked, you know, why, why are we using it? Was it purely because of UNICEF? And the staff said, no, UNICEF plays a big part in it, but if it wasn't worthwhile, it wouldn't be used. So there was lots of really positive feedback around chins. And they did say that it transformed some of their poor practice that they were seeing. So we had things like terms, I'll share them, they were colloquial terms, dangle of the angle. So obviously we're now saying, nose to nipple is what we want. And tummy to mummy. So if we think about close, in line, some of that language has changed because of chins.
Lynette, I'm very conscious we've only got 4 minutes left.
Sorry, I'm so sorry. I'll go through the other slides because I did speak to some breastfeeding mothers as well. And one of the mothers I spoke to said it was only when she heard about chins that her baby started latching on properly. So some quite sort of positive feedback from both mothers and from practitioners. We'll probably just whiz through the next couple of slides, and Cheryl, my colleague, is going to take over now and just talk about another memory aid that we've developed, because the participants in my study said what they had was this set of principles for positioning, but then they didn't have anything for attachment. And that's the next part of our work that Cheryl's going to talk about.
Hello, everyone. I'm going to get straight into it because I'm conscious we've only got 3 minutes left. But back in 2023, Lynette and I were privileged to take part in a pilot study, which was raised by the fact that the staff wanted something to support them with latches, a memory aid, an attachment at the breast rather. So what we did was Lynette came up with 2 different memory aids. One was clasp, and the other one was latches. She brought that to a little focus group of professionals, and we had a little look at that, and we decided to take latches forward. At the time we took latches to pilot study, it was latches without an E in it, and basically the latches that we took to pilot, it stood for large gape, asymmetrical attachment or areola, top lip, chin and cheeks, hurting, and sucking and swallowing. And as you're going to see from this part of the presentation, that's been developed as a consequence of the pilot study. So we had 57 respondents in total, and they were anything from health professionals working within infant feeding, whether that be through health visiting, midwifery. It was also students in the Master's Midwifery programme as well who were influential in changing latches and how it looks today. So I'm going to go straight into what latches really means. So we settled on L for large gape. So that's looking for the baby's mouth to be open widely. The mother then moving the breast with the head tilted and the chin leading towards the breast to allow for that large mouthful of breast tissue. So the baby's tongue would move both down and forward, taking a large scoop of the mouthful of the breast tissue, and that would allow for the nipple to be aimed at the rear roof of the baby's mouth into that soft palate, preventing anything like grazing or any discomfort for mother, and also allowing that large mouthful of breast tissue rather than just the nipple and the areola. We then look at A for areola and T for top lip. So if any areola is visible, then generally that's seen above the top lip. As we've seen, and Caoimhe explained very nicely in her presentation, every woman's anatomy is different, and the breast can look very different for lots of different women as well. So it might not always be seen, that areola, but if it is, it will be visible above the top lip. And then this would result in an asymmetric attachment, so allowing the baby to be in an optimal position to commence that breastfeeding. The C for chin and cheeks, so the baby's chin would be leading. That would indent the breast, and it would allow the cheeks to be full and rounded, filled with that breast tissue. And again, not just the areola and the nipple, as sometimes can be observed in practice if it's ineffective attachment. So observing that, it's really important to say that whilst we say in large gape that the mouth should be open when the baby attaches to the breast, actually that should continue throughout the feed. The baby's mouth should be wide open. If we're seeing a baby slipping back from that breast, then there could be concerns that the baby's then not effectively attached after initial effective attachment. Can we go on to the next slide, Niamh? Thank you. So one of the biggest things that came out of the pilot study was the fact that especially the MSc midwifery students felt as though the H for hurting was quite a negative connotation with breastfeeding, and that we should come away from that negativity and start thinking about actually open that question up to the woman and ask her, how does it feel for you? And let her explain that for herself rather than asking in terms of the language that we might feel we should use. So H then changed as a result of the pilot study to how does it feel? So checking in with the mother and the baby to ensure that the feed is as comfortable as it can be, and talking to the mother and opening up a conversation around the feeding experience. E being examine and explore. So it's about observing that feed, observing a whole feed from start to end, and seeing not only how the baby positions and attaches, but how it attaches and remains on the breast throughout the feed. What does that breast look like when the baby's removed from the breast? What does that nipple look like? Making a thorough assessment and examination, and then allowing us to then use that assessment, the information we get, to then explore future support needs and future feeds as well. And then S for sucking and swallowing. So that's us looking and listening for sucking and swallowing, but remembering that actually this will be appropriate to the age of the baby. So whilst we might not hear audible sucks and swallows in the very early days, after the milk does come in, then that can change. And some women might never hear that as well. So it's about being open and discussing that as well. Can we have the next slide, Niamh? So the resources, you will have seen the video for LATCHES earlier on. If you do happen to scan the QR code, it will take you through to the Northumbria University Knowledge Bank. And within that Knowledge Bank, you can scroll down till you find CHINS and LATCHES, the memory aids, and you can obtain both CHINS and LATCHES infographic sheets for free, but you can also access the video as well, which is an 8-minute video that tells you all about how we generated the pilot study and why it came about and what the result of that was. Thank you, Niamh. Next slide. So just a little evaluation of the importance of CHINS and LATCHES. So it's really important that we support all health professionals to be able to provide the most effective support to women and families, to allow them to feel empowered in their breastfeeding journey, and as Caoimhe was mentioning earlier on, to support that journey, whatever that looks like, but to be able to empower the workforce to allow them to support those women as effectively as possible. We know there are shortages in England of both midwives and health visitors, and these are key professionals that are at the forefront of delivering this support and this care. So we need to provide them with something that can really empower them in their role and allow them to effectively support women. There is evidence around students not feeling adequately trained, and that's something that we focused on within the university with regards to the infant feeding training we deliver. And I know that's been done elsewhere with Niamh and Denise at the University College Dublin as well. So it's about not only developing the skills within university or within practice, but also about retaining those skills over the course of their career as well. Against all of the pressures and prevention in access to training, but ensuring that brief training might be of value in the sense that it can offer regular updates and it can remind staff of training changes or key strategy training and changes to anything that might have been developed in the meantime. So rather than replace, we should be accepting the evidence-based approaches that are there, but delivering that in a way that people can use. We have the next slide. I think that, so I know that there's questions coming at the end, Niamh, so I'll leave that. But just as a bit of an aside, just to let you know that obviously CHINS and LATCHES are not designed to replace any formal breastfeeding education and practice, but we recognise that they might be very helpful to people who work well with memory aids and who really value the use of a memory aid in practice. We hope you enjoyed the presentation. Thank you.
Thank you very much, Lynette and Cheryl. And indeed, I can tell you that the students that I teach find CHINS very helpful as they are learning to support mothers on their breastfeeding journey. So it's wonderful to hear you both speak about the history behind CHINS and LATCHES today. So thank you both for that. Our next presentation now is Dr. Sonya Quinn. We're really looking forward to hearing Sonya's presentation. Sonya is an expert in the area of breast pumps and breast shields. Sonya is an international board certified lactation consultant, and she is the lactation consultant behind the Breast Tech, a private practice focused on bridging the gap between clinical lactation care and emerging breastfeeding technologies. She has a special interest in breast pump technology and is passionate about helping parents achieve better comfort and milk removal through properly fitting flanges. Sonya regularly provides education to healthcare professionals and is dedicated to improving breastfeeding outcomes through evidence-based practical support. You're very welcome, Sonya.
Thanks very much, Denise, and thanks everyone for tuning in today. It's been fantastic presentations already. It's a tough act to follow. So I'm going to talk a little bit about breast pumps and breast shields and how they can support breastfeeding success and how you guys can all play a part in helping with that. So just some disclosures, I do run an online e-commerce store that sells breast pumps and breastfeeding related accessories among many other items, and I am an IBCLC in private practice. So why does this all matter? Well, at the moment, we don't have any data on how many people are actually using breast pumps in Ireland as in breastfeeding families. There was a survey in the UK that did include some people from Ireland. We found that over 97% of people there had expressed breast milk and had used a breast pump. And while it was conducted in the UK, we are quite alike, and it's the closest information that we have to work from. Incorrect use of pumps and or fit of breast shields can lead to pain, can make low supply worse, and it can lead to early weaning. And so healthcare professionals do play a vital role in guiding their effective use. I do also want to call out that breast pumps and their accessories are not free or not always cheap, and that cost can be a barrier to some people who are trying to gain access to them. So we'll talk initially about the four main types of pumps and their uses, and we'll get a little more in detail then with some of them. So your first kind of pump, I'm sure most people have seen at this point or at some point, would be one of the manual pumps. They're operated by hand. Their cost will range from something like 20 euros from a generic off-label hand pump to up to 60 euros or more for something that's more expensive or like a big brand name. These are great for occasional use for travel, and some people actually really love them. They work really well for them, and they would prefer them than over an electric pump. So it's what people work best with. Then we have electric pumps. They are the most common that we see. People might be using them daily. They're not always a double pump. They can be a single pump, and their prices can vary wildly. If you have a rummage around the likes of Amazon, you can pick up some cheap electric pumps for 50 or 60 euros, but just to bear in mind, it can be a bit of a false economy. They don't tend to have strong motors that will last. If they are some of the more obscure branded or unbranded pumps, it's much harder to pick up proper valves and membranes for them that do need to be replaced frequently to keep the pump working well. And those cheaper pumps may have a negative impact on supply for those who are the most sensitive to it. So just to be a little bit wary of them. And then we have our hospital grade pumps. And I have a little red flag in here because I'm going to talk about the term hospital grade on the next slide. We also have our wearable pumps. So for our hospital grade pumps, I'm sure everyone has seen the likes of the Symphony or the Caoimhe. They're the most common in Irish hospitals. There is an option for parents to rent them so they can have the same pump at home if they're discharged. Some hospitals do seem to have some available to maybe lend to people short term or through public health nurse. It's not guaranteed, and the cost of kind of renting a Symphony, for example, is about 110 plus 40 for your collection kits, about 150 a month. And the Caoimhe is a bit cheaper. It's 95 a month and then 40 for your collection kits. Some places will have discounts for pump rental if you're with certain associations. I think Irish Premature Babies had one. I think members of the Down Syndrome Association might get a discount as well. Some things to kind of note about them would be their flange sizes, and I will talk more detail a little later on. But typically you're looking at sizes 21, 24 or 27 for your Symphony, and you can get like 26 is the kind of standard for the Ardo, and there are some inserts you can get to put into them, and I'll give you more information about that in a little bit. The wearable pumps are becoming very popular, very fashionable. They vary massively in cost. Again, if you're digging through Amazon versus if you're paying for a top name brand, there's huge variation in the pricing. You can also find the likes of wearable pumps on places like Temu and Shine and Amazon, but just to be wary if they're coming from other countries that maybe don't have as tight regulations on materials that we might have here in Europe or even from America. And again, like I mentioned with the electric pumps, they can be a little bit tricky to get spare parts for or to replace membranes and valves. And it can be just tricky in terms of how good they are. You might, if you have some time, go onto Amazon and type in wearable pump. You'll see a lot of them look the exact same with just different branding. And in a lot of cases, what's happening is there are essentially the same pump. They approach companies and they're like, hey, do you want to sell a breast pump? You can put your logo on it. I know because I've been approached in this manner with my e-commerce business. Did I want to have my own breast pump? No, I didn't, because I would have no control on any of the design or any of the features. Literally, it is just sticking a label on them. So yeah, just to be aware that you get what you pay for in a lot of cases with these. But they do have a use for people squeezing in an extra pump session here and there. Okay, so just back to hospital grade. And this is one of my little bugbears. The term hospital grade, there's no standard definition for it. It is not regulated, it's not protected, it varies from manufacturer, but we all have an idea of what we think hospital grade means. So just to hammer the point home, we're looking at a multi-user design. So it's safe for multiple people once they have their individual accessory kits. They are definitely a closed system. There's no milk going back into the motor, into the mechanism. They're designed for frequent and long-term use. They are absolute workhorses. They will work 24 hours a day. There are some specific pump features with them, and it's much more based towards patient needs rather than marketing labels. And they would all be double pumps. And interestingly, a research study has shown that double pumping gets on average 18% more milk, and that this milk has a higher energy content, which is just a useful factoid to tuck away in your brains. The study is linked at the end of the presentation. So one of the most common ones that we're going to see would be the Medial Symphony. It's designed specifically, they have an initiation program that will build and help to bring in a good milk supply. And they have their maintenance program then as well. It's a multi-user breast pump for hospitals and home rental. And I've mentioned the two programs. So sometimes this point goes over parents' heads, especially if you have a family who maybe have a baby who's come very early, they're in SCIBU, they're in NICU, they're in a bit of a fluster. They weren't expecting to be here so soon. And they certainly weren't expecting to be breaking out the breast pump on day one or day two. So we have the initiation program. And with this one, to get into your initiation mode, you have to push the let down button within 10 seconds to keep it in the initiation mode. And what that initiation mode is, or why it's different, is it will have large proportion of non-nutritive sucking to stimulate the breast. It has short bursts of nutritive sucking to gain the small amounts of colostrum, but then it also has little pauses and rest periods of varied length. So just to make sure the parents know the difference, you'll see dots if you're in the initiation mode. If you're in the maintenance program, you'll see little drops. You can see the picture on the screen there. With the maintenance mode or the maintenance program, it's a biphasic pattern. So it has the rapid quick sucks at the start to elicit your milk ejection, and then it moves into slower and deeper suck to remove the milk from the breast. So just to make sure parents know the difference. And then we have to know, when do we move on from initiation? When do we move into the maintenance program? And the little markers here are once you get to 20 ml or more from both breasts combined during a pumping session, or when the physiological markers of milk coming in become apparent, or no later than day 6, we move on. We also have the Ardo Caron pump. It's another very reliable multi-user breast pump. It has individual phases, and it has a sensitive program. So the individual phases is quite nice here. You can control and change the vacuum level and the cycle speed so that you can tweak this more to what you feel works for you or what is comfortable for you, because people are very different in how they respond. And some people love a fast cycle speed, and some people will find that slower speed is what works well for them. And of course, vacuum level can also be controlled on the Symphony. I didn't mention that, but you have your dial for adjusting it. The Caoimhe does have a program for sensitive nipples. If someone is particularly sore or tender, it just has smaller steps in how it changes to make it a little easier on people. The Caoimhe starts in stimulation mode, the rapid sucking. It's an orange background, and it will change by itself to expression mode, similar to the Symphony, if it's not tapped within the 2 minutes. And you can switch back if you need to by tapping the mode button again. So they're the kind of big workhorses from the hospital. And again, they can be borrowed and loaned out as also. So then a popular pump that we see is the Spectre S1. Now, Spectre themselves will mention that this is a hospital strength or hospital grade pump. And while it is quite a good pump, I wouldn't put it up just there with the Symphony and the Caoimhe for those early days. But once milk is in, it's quite a good pump to move on to, especially if someone is looking at any kind of prolonged pumping. From a monetary point of view, €200 gets you the pump and the 2 collection kits. And if we think back, to rent a Symphony for a month is 150 and the Caoimhe is 135. So if it's going to be more than 2 months of pumping, you're nearly better to get something like this that you will have then moving forward. Similar to the Caoimhe, you have your 2 different modes, stimulation and expression, and you can also change up your cycle speeds and your vacuum levels for both of those. It is got a really good, or it has a really good motor. It's rated for over 1,500 hours of pumping. And they do, as I say, consider hospital strength. It has a rating of 270 mmHg compared to the Ardo or the Symphony, which have 250. But again, it's a good pump to have for a reasonable price. So a little more about the wearables, just because they are becoming so very popular. The majority of people just won't continue to build up and to maintain a supply if they are just using a wearable pump. So sometimes you have people maybe with those NICU or SCIBU babies, they've used the Symphony for a while, and maybe baby's not just home just yet, but they want to maybe not pay for another month's rental, or they're coming out and they need to buy a pump. And some of them are looking at buying the wearables. It's not the best thing to move on to. I certainly would never recommend them as a primary pump, as the main pump, because they don't have the staying power, and there's just too many people who don't do as well with them and don't get full milk removal. But as a secondary pump, they are so useful. They do have a place, and it does let busy parents get in a pump session or 2 that they may not have otherwise been able to fit in during the day. And sometimes done is better than perfect. Now, of course, there is always an exception to the rule. You will come across somebody at some point who uses a wearable and does a fantastic job with it, gets great milk out with it, is comfortable, is happy. That's fantastic, but that is the exception to the rule. And there are huge, huge variations in the cost. So for about €100, you can get a double wearable pump on the likes of Amazon, compared to if you want to spend an eye-watering €650 for a double LV wearable breast pump. So just kind of factor in, if you are going to have it as a secondary pump, you probably don't want to spend €650 on it. So then moving on to breast shields, I know we're tight on time, so I'll try and keep this as quick as we can. So this idea of one size fits all, no, it does not. So many people are handed, it seems from talking to mums and parents, so many are handed out a 24 in the hospital, and it seems that it is the most available size in the units. And it's also the default size that's included with so many pumps. You can also find some 21s and 27s in the hospital settings, but like really, newer research is out there now that is backing up moving people into smaller size flanges, moving away from measuring a nipple and adding 3 to 5 millimeter to it. 24 millimeter is massive. And in the majority of people that I work with in private practice and sizing flanges, we don't get past 19 in terms of sizing. Now, obviously, I'm not seeing everybody in the world. There will be some, as I say, there's always an exception, but 24, please don't think of it as default. Please ask the question, what size does this person need? And I will give a link for the study. It's in the Human Journal of Lactation, or the Journal of Human Lactation. There's linked at the end, and you can have a good read of that. It is a fantastic study. So Anatomy affects the fit, the nipple size, the elasticity, the breast shape. If you have a good fit, it improves milk removal, it improves the comfort. Pumping doesn't have to be such a horrible thing to do. Poor fit can reduce supply or cause nipple trauma. Like I know myself, when my first baby, I was sent home pumping on a 24. In reality, it was a size 13 that I needed. And I couldn't actually get a size 13 until I had my third baby 7 years later. Okay. So this is an image here, and I suppose on the replay you can pause and have a better look at this. So some signs of a good fit: only the nipple being pulled into the tunnel. The sides of the nipple can touch the walls of the tunnel. And I know for some people that's very much like, oh my gosh, oh no. No, but actually it can, and it can be quite comfortable. Just the nipple moving a little bit back and forth in the tunnel and seeing milk spraying during pumping as opposed to always just little dribbles. Best to pump 15-20 minutes, both sides at a time, and it really should feel like nothing or a gentle tug. I have size people who've come here to the clinic and they will be coming in at 24 and they're like, oh, it's okay, you know, I'm okay. And we might size them down to like a 17 and it's like, how does that feel? And they're like, actually, this is comfortable. I had nothing to compare it to. This is now comfortable. The 24, actually, I don't want to go back to that. So it can be done. It seems scary to go smaller, but for a lot of people, smaller is the way to go. So to figure out where to start with flange sizing, if you can get a measurement at the tip of the nipple as a starting point for where to start, and in an ideal world, we'd have someone try the size above and the size below. Signs that it's too large or too big, things that can happen here. It will hurt, they'll get less milk, it'll be drips, not sprays. Your nipple might be moving side to side, pumping will take longer, there's more chance for nipple swelling. The areola goes into the tunnel and can also swell. So these kind of ideas of having that much space around the nipple and the tunnel, it's outdated, and the newer clinical evidence will show that this is too large. And as I say, I have that linked for you. That's just another image of all kind of 3 fits together. I'll skip through it because time is short. This is the ScanMe code for the journal. It's the Flange Size Matters, Comparative Pilot Study of Flange Fits. It's by Jeanette Meisside-Frem. It's fantastic paper, honestly, you know, it makes great reading. Just very briefly what its findings were: that flange fitting should be tailored to each individual. Measurement at the tip of the nipple is a good starting point. Using standard fit flanges, so the likes of the 21, 24, 27, there was less milk and less comfort. Instead of assessing for the least amount of pain or reduced pain, the goal is to have people pump in absolute comfort, and it can be done. On average, participants got a ½ ounce more milk per pumping sessions with the smaller flanges. And they do mention here that the most common sizes that they turned up as being the ones that fit it best in the study was 15 and 17. But just to bear in mind that when the study was being done, they could only get 13, 15, 17 and 19 in conical and classical shapes. There are now in between flanges, so you can get a 14, 16, 18, and there are more options now. So then there's just some other kind of flange options. So we don't just have the likes of our, like, you probably don't see these very well in the video, but there's more than just the Medela or the Ardo. There is the likes of pumping pals, which are angled, which are really comfortable as someone is doing a lot of pumping. They don't have this feeling of hunching because the tube itself is angled. You can get the likes of these little inserts, and these lactation hub inserts fit fantastic into the Ardo Carum pump insert, into the shells here, which means that mums in the hospital can get the proper size for them if they're doing a lot of pumping. You can get the same kind of inserts for the Medela. You can get inserts from most pumps, or you can use these little adapters where you can then get the size you need and you can just connect them like this. And it means it's really quick and easy to try different sizes. There's different shapes of flanges. You have the Comfy series, which has the kind of little ring around it, so it's not digging into the breast tissue. You've got the Pano, which is a wider kind of breast shield. You've got Crater, which suits nicely any kind of bowl-shaped breasts. There's so much more to it than just the sizing. Okay, because I know we're tight on time. What can you do? So just ask parents, are they comfortable, how their output is, what size are they using? Remind parents that they should only feel a gentle tug at most. There really should not be pain. Observe for any visible issues like swelling, and empower parents to advocate for a proper fit. So good signs that it's fitting well, centered nipple, pumping parent is comfortable, you're getting a good output with sprays. Red flags if there is any pain, swelling, persistent low supply. And don't be afraid to refer to an IBCLC, ideally one who is knowledgeable with flanges, so that things can be improved. And thanks for your time. And there are your footnotes.
Thank you very much, Sonya. It was so interesting to hear your presentation today. You certainly have a lot of knowledge in relation to pumps and flanges, and for our attendees listening today, that's made a huge difference to their knowledge as they support breastfeeding women. So we really say a big thank you to you for joining us today. At this stage in the presentation, I'd like to thank all our presenters today. Thank you, Caoimhe, Cheryl, Lynette and Sonya, you have been all wonderful. We will have time for a few questions, Niamh, I think. Can you see any questions there coming in, Niamh?
I'm going to have a look now. So there's just some comments there saying excellent presentation. So there is Caoimhe. The first question is for you, Caoimhe, and it was, what are some of the most common emotional and psychological impacts you observed in mothers experiencing low milk supply, and what support strategies have you seen implemented that have helped address these?
I suppose shock is one of them, for mothers who had intended to exclusively breastfeed and without even realizing it had, I suppose, shaped a motherhood self-identity, that it was intertwined with being an exclusively breastfeeding mother. In the antenatal period, when they then find that they can't exclusively breastfeed, they are in shock because this is all new information for them. And then from that shock can come anger. And as time goes on, a sense of grief. And for very many mothers, a deep feeling of shame as well. And that's one to watch, because when people feel shame, they quite often will isolate themselves from other people or other breastfeeding mothers. They will not go to the breastfeeding group because they don't want to be seen to be supplementing. Of course, all the breastfeeding groups are welcoming places, but this is just how mothers internalize it. And then isolation can then, result in even more feelings of being marginalized and feeling depressed or anxious. So really, it's a whole cauldron of emotions that mothers go through. But I think they're really concentrated in the first 3 months postpartum. The one thing, well, there's a couple of things that I think can really help mothers. One of them is to acknowledge that primary low milk supply is a phenomenon that a small cohort of mothers experience, that they are not unusual and that they are not the only one. It's very important for mothers to link in with other mothers who've had similar experiences, whether it's a neighbour who's had primary low milk supply, or whether they come to the low milk supply support group, or they find a group on Facebook, whatever it is, that they find others who they can identify with, because it helps them to feel supported and to feel less alone. And that can really help them get through those difficult few months.
So much, Caoimhe. Yeah, and I know you did mention about the peer support and just the importance of that, and also normalizing, that this can happen, so that they don't feel that it's just them.
Yeah.
Thank you, Caoimhe. That's excellent. The next question for either Lynette or Cheryl, or the both of you can contribute. So it is for healthcare professionals new to breastfeeding support. How would you recommend they integrate CHINs and LATCHES memory aids into their practice effectively, and avoid simply using them, say, as a checklist?
Well, that's quite a tough question. I don't know, Cheryl, you might be a better position to answer that to me, because Cheryl continues to teach student midwives and has very strong links with practice.
So I think it's important with any breastfeeding support and guidance that you're given is to start by ascertaining what knowledge a woman already has first, because what we want to do is to build on that knowledge and not undermine what the woman might already know. So I think it's about considering what her journey is to this point. So it may be that she's had a previous child and she's breastfed, and that journey's gone very differently to how she'd expect. Or she had a previous child who she formula fed and used bottles for that. So it's about ascertaining what knowledge she has to begin with so that we can then build on that. So whilst we might want to use the memory aids as a bit of a checklist in our head, that's not how it should come across to the woman. We advocate a hands-off approach with anything. So it would be observing that feed. It would be observing what the woman's already doing. So we're thinking about how does the woman hold the baby at the breast to begin with? What position is she in? How is that comfortable? We're already hitting a few things in our head because we know that if a baby's held by a mother, then that baby should be held close. So we've already got that close. That head should be free to tilt back. We can observe that as to whether the baby's head is free to tilt back. Is the baby's body in line? So when we come to talking about is the baby's body in line, we can demonstrate that with even a bottle or a glass of water and asking the woman to turn the head to the side and to drink from that and to see how that feels as opposed to drinking in a line with head and body. So we're using those small memory aids to then start building on our skills. So if you're a newly qualified midwife or you're quite new to breastfeeding support and practice, then this checklist is more for you than it is for the woman. CHINS is really good when you leave a woman because it can help her feel empowered that she's got the baby close, she knows the head's free, she knows that the baby's head and body's in line and that nose is at the nipple ready. But actually at the time that we're educating women, we should be thinking outside of that box and keeping that checklist in our head. The same with latches.
I was going to say some of the theory that, you know, when I was a student nurse myself, it is going back quite a long time now, but we talked about Benner's novice to expert theory. I don't know if colleagues are familiar with that. Niamh's nodding, Denise. And what it says is that, you know, very often when we are new to practice, we might use things in more of a checklist way. But actually, when I conducted the UK evaluation of CHINS, that was one of the questions that I asked. I said, you know, is it more beneficial to new staff? And practitioners who'd been qualified a lot longer said no. And the idea behind memory aids is that we kind of use them, like Cheryl said, it is a way, like sort of in our internal monologue, it is a checklist because the order of CHINS is quite important. That, you know, those are kind of principles that might have a particular order that then help for the positioning to be done, you know, so it's effective. So I don't know if there's any harm in having things as a checklist. I think it's just, you know, we want to actually, and I don't know who talked about it, rapport. We want to actually move away from people feeling like that we're approaching visits with a set agenda, a set checklist. And certainly, I think when I spoke to breastfeeding mothers, if you look back at some of the slides I skipped, what they said was that sometimes professionals come in with a set agenda and that doesn't actually meet what they want. So one of the things they said was very early on, you know, when we do sort of initial visits, practitioners wanted to talk about contraception. And they said, well, actually, contraception and sex were the furthest things from their minds. What they wanted was practical advice. They wanted help with breastfeeding or feeding their baby or aspects of caring for the baby. So I think it is about, you know, just checklists are great, but we actually have to develop relationships. And really, certainly as an educator, you can have vast amounts of knowledge, but if you can't work with the learners and your colleagues, and if you can't develop that communication and that rapport, you're not going to share that knowledge effectively. So those relationships, I think, for all practitioners are really fundamental. And it's only when you've got good rapport and good relationships that the people that we're working with feel able to tell us what's important to them. So I think that's just a reminder that came out of speaking to breastfeeding mothers for me.
I think the final thing to say is to remember what side of the brain's working after a woman has a baby. That right side of brain, which is all around emotions, it's around touch, it's around sensory, rather than that logical side. So by giving a woman that memory aid and just saying, this is what you have to work down, it's not necessarily going to work for them. But what it will do is to, as Lynette says, it will jog the memory of the practitioner to be able to systematically and methodically approach infant feeding in a way that is going to be meaningful to the woman, so that she'll remember how that felt when she held the baby in the right position. She'll remember how that baby went to the breast and how the feed felt. So it's about logical for the practitioner, but how it felt for the woman on the other side of that as well. Thank you. I hope that answers.
It does, absolutely. Thanks, Lynette and Cheryl. And it is they are fantastic tools to help guide your assessment, to kind of, as you're working through it. And I know Denise and I have used them with midwifery students, and it's been fantastic in terms of education. Denise, have we any more questions? I know we've ran over time. We might have
Yes, I have a question for Sonya. Sonya, for as long as I can remember, the breast shield size 24 has been standard with every pump. Where did that come from in the very beginning? Would you have any idea?
Yeah, it's actually it's a funny story, that. So years and years and years ago, when breast pumps were first being manufactured or designed, the men in question who did that, I suppose, drew from the dairy industry, and a lot of the sleeves that cows are milked in are 24 millimeters. And where it came from. And I've been meaning to go and talk to the farmer down the road and say, like, can I get a picture with your cow? And I might yet. That's where it kind of came from, and no one knew the difference to ask otherwise.
Yes, I know, so interesting, isn't it? Yes, but I look forward to further research in this area, really in relation to breast pumps and breast shield size. So that was very informative today for us. So at this stage, we're at the end of our presentation. Thank you so much to all our wonderful presenters. You really have enlightened all of the attendees today and increased their knowledge and skills as they're supporting the breastfeeding workforce. And we really appreciate our colleagues attending from the UK as well, and sharing the chins and latches from the UNICEF UK Baby Friendly Initiative, and congratulations on achieving that, which is wonderful. Thanks so much to everybody. It was a pleasure to present alongside Niamh today. We love our webinars, and we look forward to future webinars and having you all join us again. So have a lovely afternoon, everybody. Thank you so much.
Thank you so
Thank
much.
you.
Take care, everybody.
Thank you. Bye.
Thank you. Bye.